Active surveillance is a big topic, but I'm going to try and focus a little bit on a couple of areas. One area of interest of mine is whether or not we can expand the active surveillance criteria to include the low-tier intermediate risk patients. I'd like to also explore some of the outcomes after radical prostatectomy, some of our data here from UBC as well as other recent published cohorts, and a little bit about how we can integrate MRI into our surveillance protocols and whether there's any role at this stage with genomic predictive tools. So like any good talk, first thing to do is look at the guidelines, but the NCCN guidelines just got updated this year in January, and you can see there in the red box that very low, low and intermediate are now heading in a similar direction. So there's certainly no question that very low and low should be offered active surveillance as a initial management step, but the intermediate is more controversial, and if you look at the small print, and I'll just blow it up for you, this has now appeared in the NCCN guidelines. Patients with favourable intermediate risk prostate cancer may be considered for active surveillance. See discussion section. So we'll expand on that. And I'll talk about what favourable intermediate risk means in more detail. So where is this coming from? Not all intermediate risk prostate cancers are alike, as you probably know. This paper from Reese et al. At Oncology looked at 12,000 men who had radical prostatectomy at Johns Hopkins over 10 years. It's a lot of radical prostatectomies. And they found that the rates of biochemical recurrence were quite different depending on what made you intermediate risk. And certainly Gleason 7 portends the worst risk for that group compared to clinical stage, which is notoriously unreliable, and PSA, which is an interesting point. So, favourable versus unfavourable intermediate risk. What are we talking about? So I'll just, before we go on, I want to put it to the audience. Is this statement true or false? In 5 years, we will be offering low-volume Gleason 3+4 active surveillance as first-line management. Who thinks that's true? Only one take, two takers.
Depending on volume.
Depending on volume, okay, well, we'll talk about that. And the naysayers? The rest of the room.
It's an option.
No, my problem is I've never had the glories of the MRI to look at and stuff.
Mm-hmm.
But how accurate is your assessment to start with? I mean, you got it up there in black and white, like you know what you're dealing with. And most of the time you do. And I'm sure you guys are a lot more accurate in this sort of thing than they were 20 years ago, but can you look the guy in the eye and tell him you really know what's in his prostate?
Well, maybe increasingly yes, with MRI,
Yes,
as you pointed out, and also with better risk stratification, and we'll talk about that obviously today. So if this were to happen, could we be looking at a reverse Will Rogers effect? Larry, Dr. Gobler? It's false?
It's not 5 years, it's now.
It's now, okay.
Yeah, now low volume is the people, but it's not active surveillance. It's active surveillance would probably go related to that. That is, we're just at an earlier time in the biological timeline of the disease, inevitably there's probably a time when there's a high probability that they will treat. The question is how do you monitor them and how do you know when?
Well, I would question that. I think that's what we're heading, that's the difference. We're heading towards a situation where we'll comfortably say, okay, this guy's got low volume Gleason 3+4, he's got a small percentage pattern 4, he's got an MRI which is normal. This guy's actually safe to monitor long term. That's what I would put it to you. So who is Will Rogers? Every time you go to a conference, you hear about the Will Rogers effect.
It's a famous cowboy from Oklahoma.
So he was a comedian from Oklahoma, and maybe a cowboy. And he said when the Okies left Oklahoma and moved to California, they raised the average intelligence in both states. So essentially the Will Rogers effect was when the ISUP regrading in 95 moved the low-grade Gleason 7s out of the Gleason 6 group. It improved both groups' prognosis because you're sending the bad actors out of the good group, and the bad acting group receives the better prognostic group. So when we look at favourable versus unfavourable intermediate risk, we're talking about only one intermediate risk factor out of the so-called D'Amico criteria, Gleason 3+4 or less only, and less than 50% of the cause positive for prostate cancer. So 5 out of 10, no more than 5 out of 10 cause, 6 out of 12, etc., which is quite a high threshold, I would have thought. And unfavourable is the corollary of that, obviously. This originally came from Zubsteg and Zalewski's work, European Urology 2013, where they looked at 1,000 patients in intermediate risk treated with external beam, and they found that those with unfavourable intermediate risk, as just defined, had much poorer rates of PSA recurrence-free survival, distant metastasis, and prostate cancer-specific mortality. So just to share with you some of our own data from UBC, we looked at our intermediate risk sub-cohort from our active surveillance group. So out of 650, we had 144 intermediate risk by NCCN criteria. And then when we stratified them by favourable versus unfavourable, you can see the difference in their progression on active surveillance. It's quite striking. So how else can we stratify intermediate risk? There's a CAPRA score out of UCSF. This is a very good tool, and you can see there how it's broken down. You've got, do I have a pointer here? Yeah, so you've got PSA is now stratified into a point system, okay? So that means that even if your PSA is over 10, you don't automatically get lumped into intermediate risk, but you rather get a score of 2. And your Gleason score puts a heavier weighting on having a primary pattern 4 or 5, and you get a score of 3 for that. The T stage is now dichotomized into, if you have definite T3, then you get 1. Okay, so, oh, sorry. So, you know, even having a T2 stage doesn't attract any points. So that's an interesting change. PPB stands for percentage positive biopsy. So they're saying if you have less than a third of cause involved, you get no points. If you have more than a third of your cause involved, you get 1. And then interestingly, they put age on there because of within their modeling, they found that the older you were, the more likely you were to progress. And there is some mounting data that the older you are, the more likely you are to harbor a bad cancer on active surveillance. It's an interesting one. So there's an emphasis on pattern 4 and 5. It breaks down PSA, and there's a de-emphasis on clinical stage. And so when you look at how it breaks down, 0 to 2 is low risk, 3 to 5 is intermediate risk, and 6 to 10, or 6 and up is considered high risk. And if you look at how the D'Amico group breaks down in CAPRA, you can see that the intermediate risk group really spreads out over the point scoring system from low to intermediate on the CAPRA scale. I just wanted to show you this because this was in a review that just came out this month. This is CAPSURE data from Cooperberg, and it shows us, it's broken down into CAPRA categories, low, intermediate, and high. The amazing thing is that in the low risk group, you can see the advent of active surveillance here from 6.7 to 40% for the low risk group. And you can see here, which is interesting, in the high risk group, the purple is surgery. Okay, so look at the increase in the use of surgery in the high risk group. The other thing that I always like to see is the reduction in the orange bars, which is radiotherapy. Got nothing against them, they're lovely people, but it's inferior treatment. So, UBC data, this is our cohort of 650 patients on active surveillance stratified by CAPRA risk group. And it really separates the curves nicely from low to intermediate CAPRA, showing that if you've got a low CAPRA score, despite your NCCN stage, you're much more likely to stay on active surveillance progression-free on biopsy. This is a seminal paper from Plusard et al. In Urologic Oncology a couple of years back. The title was, It's a very good paper. You just wait and listen. Well, I don't know why it's not in European Urology, but it should be. Can we expand active surveillance criteria to include biopsy Gleason 3+4 prostate cancer? So they looked at over 2,000 patients from multiple centers across Europe. They looked at radical prostatectomy data, and what they did was they looked at those who had Gleason 3+4, and then they found the ones that also had these low-risk active surveillance criteria: PSA less than 10, PSA density less than 0.15, clinical stage T1 and less than 2 cores. And they managed to show very nicely that as you add those risk factors together, you increase the rate of biopsy upgrading during active surveillance, biopsy upgrading on your radical prostatectomy, and unfavorable disease. So if you look here, if you have none of these other risk factors, your chance of downgrading is nearly 20%. And your chance of unfavorable disease is only 19%, not very high. If you think about the average man who you submit to prostatectomy with intermediate risk disease, his chance of unfavorable pathology is usually around 30% across the board in the literature. If you have one risk factor, it goes up to 38, and so on and so forth. So it goes up to 57% chance of unfavorable pathology if you harbor multiple risk factors in those criteria. So very valuable data. So I just want to now turn to PSA density, because this is really gathering a lot of momentum in the literature. This is not a new concept. Epstein in '94 presented this graph on PSA density, and they've set the threshold here at 0.1 at the time. Subsequently crept up to 0.15, and it sort of stayed there. And 0.15 is something that's been handed down from generation to generation as a threshold for PSA density of significance. And just late last year, the UCSF active surveillance cohort was represented in J-Urol, and they found that PSA density was an independent predictor of biopsy progression and progression to treatment while on active surveillance. And if we look at these are some of the big international active surveillance cohorts, we start to see this pattern developing: PSA density, PSA density, PSA density, and so on. So a very simple tool to use, PSA over prostate volume, something that I think we all should be doing, because it's reducing the impact of a big prostate volume on your impression of what that patient's PSA is, and it's a better predictive tool. So here's our own data from UBC. This is a multivariate analysis on our active surveillance cohort. And Gleason score at baseline, so if you had score 7, you had a 1.6 odds ratio of progressing. But this, the p-value is 0.055, so it's just on the cusp there. But look at the others. Percentage positive biopsy, just like the Capra score, highly significant. PSA density, highly significant for progression.
So can you go back? So this is high PSA density.
Yeah, greater than 0.15.
Smaller the gland. Yeah, so, yeah, no, I understand that it predicts for. I'm just trying to think that. So the great. Higher the density, the greater the risk for progression.
Yeah.
It just be so that that means that the smaller your gland in general, then the higher the risk for progression.
Well, it just depends on your PSA,
yeah.
Right? So that's why it's a useful tool, because if you've a man with a PSA of 8 with a 30-gram gland is of higher risk than a man with a 60-gram gland. Because that man's got PSA due to his BPH.
But what it doesn't take, that's what I'm struggling with, it doesn't take into consideration is sampling bias, which increases with bigger glands.
Because so bigger glands,
you're
less likely to hit cancer?
There's a lot more space between the lesions. So
yeah,
that's why I've always had a hard time reconciling the density issues, because you're much more confounded by missing significant cancers with the bigger prostate.
Mm-hmm. Yeah.
I don't know how to reconcile that.
So let's have a look at the current prospective trials in active surveillance. There are 9 listed here. These are the 9 big ones. Australia's finally made it on the map. St Vincent's in Sydney here. Johns Hopkins, which you're familiar with, Sunnybrook from Toronto. Big cohorts. It's the follow-up there. So the follow-up mostly is around 5 years at the moment across the board. Some longer than others. Percentage of patients treated varies between 20 and 40% roughly in their cohorts. Median age, mid-60s. Some cohorts have included intermediate risk. The Toronto famously is included 3+4s. They've got 13% in their cohort. The Australian group, 14%. And so on. Most of the American cohorts don't have any Gleason 7 in their follow-up cohorts. So what were their selection criteria for active surveillance? Clinical stages varied quite a bit. Some allowed palpable lesions T2A, some didn't. Mostly Gleason score 6, as I said. Johns Hopkins, they applied the very low risk criteria of Epstein, less than 2 cores, less than 50% of any core involved. Interestingly, the serum PSA level initially didn't matter, but they did mandate that the PSA density was less than 0.15. So you can see that, there's a little bit of variation, but most people are on the same page. It's low risk, sometimes very low risk. And the monitoring schedules, now this is interesting because when active surveillance as a concept first started, it was very hawkish. Every 3 months you had to come in for a PSA and DRE. You got a biopsy within 6 months to confirm your diagnosis. Then you got a biopsy every 12 months at some of these locations. And you get a lot of patient burnout, sometimes complications, etc. And then there was talk about, so many biopsies leading to difficult surgery if they come to radical prostatectomy, etc. The effect of biopsy on erectile function even. And that seems to have relaxed over time. We'll talk a bit about that. Interestingly, I think to point out is that the Toronto data didn't mandate examinations, but they also were only doing biopsies every 3 to 4 years, and they really relied heavily on PSA doubling time of less than 3 years as a trigger for intervention. And there were a number of patients who had only PSA doubling time as their trigger to go on to have surgery or radiotherapy, and most of that cohort got radiotherapy, in fact. But, so yeah, a bit of a spread across the group. So this just came out in this month in J-Urol from Stacey Loeb and company. How good are we at, or how active are we in active surveillance? I know that currently here we do a PSA and clinical review every 6 months, and then we often do a confirmatory biopsy within 12 months, and then now we're using MRIs maybe every 2 years and biopsies every sort of 2 years in our active surveillance group here. And what's happening in the US? So this data shows that in 5,000 men who had a prostate cancer diagnosis followed by no treatment and at least one further biopsy to identify them as active surveillance, there was good adherence to biopsy protocols for the first 2 years, and then it really drops off. And the number of people having biopsies out 5-6 years down the track is less than 10% of the group. So what's happening? Are we happy that we're identifying them as low risk and that they're not going to progress and then we forget about it? Or we're just relying on PSA and PSA kinetics, which is a notoriously unreliable predictor of how somebody's going to do, and we'll talk about that. And again,
patients are kind of voting with their feet.
Yeah.
Really, you're going to do me another biopsy?
Yeah, exactly.
I'll take my chances, doc.
Yeah, they'll do anything to avoid another biopsy, won't they? Yeah.
Or these patients are sicker and they're more in the watchful waiting pattern.
Okay, yeah, potentially. But if they're selected properly, they shouldn't be, because if you select him properly, in 5 years he still should be alive and fit enough to have curative therapy if he progresses.
By definition.
Yeah.
But not over time. You could be an accurate surveillance patient, and over time, it becomes more of a watchful waiting.
Sure, but if the average age of entry to active surveillance is 65, by the time 5 years happens and you're 70, you should still be fit enough to have curative therapy. And there's a question, yeah?
I was just wondering, the attrition of numbers over time, do you know how that gets divided into active treatment versus death of other causes versus loss of follow-up?
They only included men who hadn't had treatment. So these are men who are still supposed to be in active surveillance and alive. So they accounted for that. Are you saying that it could be because they've had surgery or radiotherapy or died or moved on? Or
No, I'm just asking.
I think they weeded those out.
Right on the numbers, starting with 1,300 and 5 years later, you only have 270. So 1,000 men, how many of them have got active treatment versus death from other causes versus loss of follow-up?
Yeah, I don't know the answer to that. It's a good point. Good point. So then this graph just shows that the grade 6s tend to move on early and the grade 7s tend to last longer. So is it because the grade 6s get reclassified more, upgraded more perhaps, whereas the grade 7s tend to be grade 7 and they continue on rightly or wrongly on active surveillance for a longer period of time. And those that had regular biopsies tended to move on, have a change in management early, whereas those who had no regular biopsy tended just to stay on active surveillance longer term. So that raises the issue of progression and what are your definitions for progression. PSA kinetics, as we mentioned, are unreliable, often in predicting biopsy reclassification and pathology at radical prostatectomy. There's a lot of inter-observer variability in pathology evaluation and identifying grade increase. And what does volume increase mean? Do you take the number of positive cores versus the proportion of cores that are involved? And now with changing biopsy techniques, we're not just all doing a sextant or 12-core biopsy, but there's saturation biopsies, there's transperineal biopsies, there's fusion biopsies. And how does that change our interpretation of the number of positive biopsies that we get back? So what do PSA kinetics tell us? As I said, there have been a lot of studies showing that PSA doubling time couldn't discriminate between those who would progress on biopsy versus those who would not. It was used, as I said before, as a trigger at Sunnybrook for intervention, but then it sort of enters a circular argument where you're saying this guy has got a high PSA doubling time, so we're going to act on him, and then it's a predictor of progression. There's some interesting mathematical work being done in the UK within the Protect trial group, looking at modelling change in or PSA age-related change as you move through active surveillance. So as you age, your growth rate may or must change, and they're looking at trying to model that using a regression spline mixed model, which I don't understand. And they're trying to compare that to PSA doubling time and PSA velocity, but they need more outcome data from Protect to better characterize that, but that's an interesting space to watch. So grading issues published in Uro-Oncology by McKinney et al. Looked at 107 patients on active surveillance. They had 11 different GU pathologists across 7 centers. They found that the agreement or the kappa score for classic Gleason patterns was good, but as soon as you had tangential glands or small foci of cancer, you had a problem. The agreement was poor. And up to 25% of those assessed had their grading in question. So we're talking about a significant proportion here. And when you're talking about a man who is having a new pattern 3+4 and a small amount of a biopsy core and then consigning him to treatment, you better be sure that you've got it right. And that's not always easy. And then volume definition issues, as I said, different places use different definitions of what is a volume that's too high to watch. John Hopkins, 3 or more cores. UCSF, a third of the cores involved. There's different ways of calculating the amount of cancer in the core. Linear length versus volume of the core involved. So sometimes saturation biopsies are taking up to 30 cores. So if you get 5 cores out of 30, is that more significant, than 2 out of 12? Hard to say. And when a fusion biopsy is done and you take 4 samples from a lesion identified by MRI, and all of those 4 samples have cancer in them, but they're all from a small lesion, what's the significance of that? Have you shifted their risk, or have you just increased the sampling? So threshold for significant cancer historically, as you know, was 0.5 cc's, and now there's been a shift to 1.3 with some new data. This came from Stamey 23 years ago, 1993. They looked at lifetime risk estimates for men with cancer, and then they sort of worked backwards, and they said, we've looked at all these cancers on radical prostatectomy specimen. If we look at lifetime risk, X amount of these must have been clinically significant and those weren't. So it's an interesting mathematical way of deriving it, but they came up with the figure of 0.5. And then in 2011, Schroeder and Vanderquast out of the ERSPC data did the same mathematical technique and came up with 1.3 cc's if you didn't have any Gleason grade 4 or 5, so only for Gleason 6s. Whereas the Stamey group was for all comers. And if you think about that 1.3 cc's, even though it sounds maybe like a lot, I mean it's not very big. And if you think about MRI measurements, to get a volume of 1.3 cc's, you have to have a diameter of nearly 2 centimeters on an MRI to make that sort of prostate cancer volume. That's a big lesion, isn't it? I mean, if you've seen MRI reports, there's not many lesions that are 2 centimeters inside. And they get called Pirates 5. They're over 15 millimeters with the appropriate enhancement and so on. So some of the long-term outcomes, these 5 studies have got more than 5 years follow-up. Their outcomes are pretty uniform in showing that the prostate cancer-specific mortality is very low, except for the Toronto group, except for the CLOTS group. They're showing 1.5% mortality. They're also, extrapolated to 5.7% at 15 years. But they're also showing a 2.8% metastasis, and this has been a bit controversial lately. And I should also point out that they've got a 15% overall mortality, which really indicates perhaps that their cohort was pretty old and sick.
What follow-up is that? Is that 5 years? 10 years?
Well, they have a median follow-up of 6.4 years.
So it's 15% overall at a median percent.
Yep.
Yeah.
And we know that from analyzing their cohort, and I think I've got some slides on it, yep. So they looked at 993 patients, median follow-up 6.4 years. 61% of the cohort was over 70. Okay, so quite a bit older compared to most international cohorts. They had 13% Gleason 7, and as part of their entry criteria of allowing Gleason 7s on, they had to be over 70. That was one of their criteria. So a lot of people have been talking lately in the literature about how there were an unacceptably high rate of metastases in the CLOTS data, and that it's all attributable to Gleason 7. If you actually look at the numbers, only 44% of those that got metastases had Gleason 7 on initial entry into active surveillance. So the majority actually had Gleason 6 cancer. And they progressed, sure, during their active surveillance, but we can't just say, oh, it was because they were all Gleason 7s.
Can you look at the data and see how median can be misrepresentative of populations where some proportions would have much longer follow-up, especially the Toronto group, which basically led the way in active surveillance protocol. So while you may have groups that all have a median survival around 5 or 6 years, the Toronto group may actually have the largest proportion mature 10 to 15 years out. So do they present the proportion of patients greater than 10 years, greater than 15 years, which is really where all the events are going to be seen?
They don't really. I mean, they do have those patients, but they're not high numbers. Of the 993, those that have had 15-year follow-up is like maybe 30 patients or something. Yeah, so it's misrepresenting to say that we've got 15-year follow-up data. It's extrapolated mathematical data. I'll show you these figures. So,
But usually it's in those Kaplan-Meiers where they show the numbers at risk.
well, they don't show the numbers at risk, but the cross-hatches are all those that have been censored, right? So you can see how many have dropped out, huge numbers early. And this just shows the on the left the overall survival, low risk versus intermediate risk, and the cancer-specific survival on the right, low risk versus intermediate risk. And this one is metastasis-free survival on the left, low versus intermediate, and biochemical recurrence-free survival for those that had treatment. So definitely a trend towards the intermediate risk faring worse, but there are some caveats there for sure. The Canary data just got published last month in Urology, another low-impact journal. And
That's the best we could do.
and they looked at 905 men, so it's a big cohort, but the follow-up's only 28 months median. And the treatment rates are low so far because it's a short follow-up, 19%. 32% were treated without pathological progression, interestingly. And 31% continued on active surveillance even in the face of pathological progression, maybe even more interesting. So that sort of, along the lines of, stop biopsying me, doc, I don't want to know. It's also like, okay, you've got, your cancer's a little bit worse. Do you want to have treatment now? No, not really. I'm quite happy with this active surveillance model that I've got for myself. And 34% had unfavorable pathology at radical prostatectomy, but they haven't really expanded on that in detail. And again, look, percentage predictors of reclassification, same as ours, percentage positive biopsy and PSA density. So radical prostatectomy outcomes from our cohort, we looked at unfavorable pathology, which is primary pattern 4 or greater and T3 disease. And we looked at PSA recurrence. There's an inherent selection bias in looking at these patients because they have their diagnosis, they go on to active surveillance, they get reclassified in general and go on to prostatectomy. So you're enriching the group with higher risk cancers. And so your outcomes are going to look worse if you compare it to an immediate prostatectomy model. So that's Will Rogers as well? Yeah, I guess it is. So we did a propensity score matching. We took 1,700 contemporary radical prostatectomy patients who had data, and from those we selected them to match against our active surveillance delayed radical prostatectomy group in a 2-to-1 match. And you can see they're very closely matched by the computer modeling. The age is slightly different, but really not that significant. Clinically, and their PSAs are almost identical, their Gleason scores are identical, their clinical stages are identical. But this is at the outset, remember, so this is the day they get diagnosed and go on to either active surveillance or the day they get diagnosed and go on to radical prostatectomy, so it doesn't take into account the progression biopsy. The time to surgery, 1.59 years for the active surveillance group versus a third of a year, 4 months for the immediate group. Average follow-up 4.8 versus 3.2 years. Predominant pattern 4 on pathology, 24% in the active surveillance group versus 12% in the immediate group. And I'll break this down into risk group categories for you. So the very low risk group had a trend towards more unfavorable pathology, more pattern 4, more T3 disease. Oh, no, I mean, their T3 is fairly equivalent. Margins equivalent. A general trend towards more unfavorable pathology, but not statistically significant, maybe because of the numbers, sample size. When we look at low risk group, this was the biggest numbers, 90 versus 180. And you're starting to see some statistical significance in the unfavorable pathology there, which is interesting. And I guess, as I said earlier in the talk, the low risk ones are the ones that are going to have Gleason 7 found on their subsequent pathologies and then go on to radical prostatectomy, perhaps it's an effect. The intermediate risk group had, again, probably because of low numbers, no statistically significant results, but you can see there's a trend towards unfavourable pathology for sure. Particularly the margin rate is quite high, 37% for some reason.
What's your interpretation of that?
Difficult to say. I guess I think, you know, if you take a man who's on active surveillance whose priorities are sexual function, and then you decide he needs a radical prostatectomy, you might be more likely to do a nerve-sparing procedure and get a positive margin. One theory.
Or is time to treatment altering the pathology?
Well, that's it. Yeah, I guess that's the big question.
Does anybody else have any other insights into? I mean, this is all trends, but
Mm-hmm.
this is a major argument as to why the prostatectomists in the U.S. have always pushed back against active surveillance.
Mm-hmm. Smith?
Those numbers just seem so impressive. So you're saying if we have a low-risk patient and you follow them for the time you said was just 1.5 years or so, the chance of getting predominant pattern 4 or 5 is 25% of those patients. Are we not stratifying them correctly then? If you're saying after 1.5 years, a quarter,
We're not identifying them correctly from the outset. Yeah. So.
Failure of selection, not failure of active surveillance.
And perhaps that's true, because we're talking about a group from the year 2000 to sort of 2014 without the modern active surveillance criteria being applied, without MRI, without better pathology reports, percent pattern 4, etc. So
That's a real scary number.
Yeah.
The patient after 1.5 years of active surveillance, you have a 1/4% chance of having predominant high-grade disease that we know is lethal type of prostate cancer. That's not reassuring at all.
That was my point before at the very beginning. How much better are you now than you were in 1999?
I think a lot better.
At taking that group of patients out of the picture.
I think a lot better, because we're doing better targeted biopsies, better pathology reporting, imaging.
So this number is old. Is there data that suggests? Have you got actual evidence of improvement?
Yeah, but that's why I would argue that a vast majority of the patients who are diagnosed up front are not getting an MRI, and they are being followed traditionally with the repeat biopsy.
This is
numbers. I wouldn't say the majority are getting MRI follow-ups.
Yeah, this is all historical data really now. This is
historical, but still, I think what's current is representative of what we're doing currently.
For the repeat
Yeah,
the
everybody.
confirmatory biopsies are all MR.
So year wait.
What's interesting though is you can't really compare, but the numbers are in the same realm, the same space. If you look at the false negative rate of MRI, it's around 20%. And that's sort of roughly where you are here with the very low risk, even is 20% unfavorable pathology with immediate radical. The other interesting point here is if you look across the line with positive margins, very low risk, immediate radical, that's a high positive margin rate, 22%.
Yeah.
Right? I mean, it's a very high, and it only goes up to 29, is that 23 or 29%?
23.
Immediate risk. Okay, so we should be looking at that as in our center as well. Of why do we have that high positive margin rate?
At the same
I
time,
think Stevenson's data from the big series, I think it's around 10% for low risk. So we're double that.
That's clinical, that's not pathological. Right?
Yes.
No, I'm talking positive surgical margin.
I know, but they are pathologically higher risk because a lot of them have Gleason 4 and 5.
No,
Well,
but
we don't know if those are the same patients.
These are, who's doing, do we have that many, 120 very low risk prostatectomies?
Yeah.
Out of 1,200.
out of 1,700. Yeah.
1,700.
risk.
Out of 1,700.
And it goes back a long time. Probably, if we did
It goes back to 2000. So
If we looked at it in the last 2 to 3 years, we probably would find that.
it Did I put the year on here? No, but I matched them for year of surgery.
That's the other thing. The further you go back to get your very low risks, the less likely it is that they were truly low risks. Right?
Yeah.
Because of
They were incorrectly identified.
Yeah. So it's a problem with looking back in history.
Yeah.
So many things alter over time.
Yeah. That's why we usually ignore most of these findings and just keep doing what we're doing.
Well, you incorporate them into future questions.
Yeah. Okay, I better keep going because we're running out of time. So this Kaplan-Meier curve just shows that despite the bad pathology, if you follow patients for PSA recurrence at a median of 4.8 years for the active surveillance group and 3.2 years for the immediate group, they have equivalent PSA recurrence rates. So far we don't look to be doing them any disfavor. So some of the recently published deferred radical prostatectomy data from European Urology, Tosoyan et al. They thought that delayed RP had a similar rate of unfavorable pathology compared to immediate controls, 21 versus 17%. And the adjusted odds ratio was 1.3 for delayed RP, but not statistically significant. The way they arrived at that was interesting, and I don't necessarily agree with it, but they looked at their Johns Hopkins active surveillance group on the left, and they looked at how many of their cohort got reclassified by grade, reclassified by volume, and reclassified by grade and volume. Then they went to their prostatectomy data and they pulled out the same proportion to represent that group. So they called this the delayed prostatectomy active surveillance cohort. But if you look at it at the bottom here, when you compare those two cohorts side by side, they're actually quite different because they've pulled out 70% who are very low risk versus 43% in the immediate group. So they're comparing a better delayed radical group to a worse immediate group and saying, look, the outcomes are the same. Take that as what you will. And then Philippou et al., also recently, June 2015, they looked at, I think this is similar to the way we did it, eligible for active surveillance, immediate RP versus delayed, and they found that there was a significant hazard ratio for unfavorable pathology in the, sorry, that should be in the delayed group, not the immediate group. Then when they tried to look at matching those that had immediate RP versus those that had active surveillance after upgrading on repeat biopsy to grade 3+4, they found that the effect was nullified somewhat. Still a trend towards unfavorable pathology in the delayed group. Again, I got that wrong, but not statistically significant with the confidence interval crossing 1. So what is the role for MRI on active surveillance? To switch gears, as the Americans like to say. Avoiding rebiopsy. Patients hate it. Risk of sepsis, cost of biopsies, although you could argue that an MRI is quite expensive. Antibiotic use to cover biopsy and its resistance problems. And if the biopsy needs to be done, the fusion biopsy can afford less cores for a higher yield and potentially a reduction in morbidity, and that might be attractive to the patient and the clinician. So what does it say about diagnosis? In conjunction with fusion biopsy, you've heard many times that it's able to show to improve cancer detection over a 12-core biopsy, particularly when there's low apical lesions, anterior lesions, big prostates because of sampling error and elevated PSA prior negative biopsy. So you're picking a better candidate or the right candidate from the outset. We can risk stratify them better. The PARADS or suspicion scores as they use in the US correlate well with Gleason grade and cancer detection. Siddiqui et al. Published this. 32% had upgrading on targeted biopsy compared to their 12-core systematic biopsy. Son et al. Showed that MRI suspicion score was the most powerful predictor of those that would have a positive biopsy after a previous negative biopsy. What is the negative predictive value of an MRI? There are claims from 95 to 100%, depending on what your definition of a clinically significant cancer is, what your definition is of a negative MRI, what your definition is of your pathology correlate, so it's a bit variable. But even if it is 90%, it's still better than a 12-core trust biopsy, which averages a negative predictive value of about 70 to 75%. So when you're talking to a man on active surveillance and you say you can either have another 12-core systematic biopsy or you can go and have an MRI, I would say that the negative predictive value is better.
That's using a different gold standard. I mean, one is using a needle biopsy as a gold standard, the other is using histology and radical prostatectomy as a gold standard. I can't compare those.
Well, there are studies that have compared MRI with saturation biopsy and looked at.
Still, the gold standard is a radical prostatectomy, and needle biopsy doesn't hit every little microscopic focus.
Sure.
So I think you can't use that as.
But all I'm saying is, when you do a 12-core biopsy on active surveillance, it comes back negative. You're reassured. You tell the patient, don't worry. But it's got a 70% negative predictive value. Whereas if you do an MRI and it comes back negative, you can reassure them with greater certainty, I think, than that it's truly negative.
With the caveats of, on top of that specificity is never in question with a histology section as opposed to an MRI.
So Stamatakis et al. Looked at the accuracy of MRI in confirming eligibility for active surveillance. They took 85 men from the Hopkins with Hopkins criteria. Sorry, they did an MRI fusion biopsy. 29% were reclassified as not suitable for AS, and so this is looking at better stratifying them from the outset, so we're not missing the bad actors who we're putting on active surveillance. They came up with this nomogram, which attributed points for the number of lesions seen on the biopsy, the highest MRI suspicion score, and the total lesion volume over the prostate volume. And then that predicts your probability of active surveillance disqualification. Rekabal et al. Recently published on the efficacy of MRI and targeted biopsy and reclassifying those on active surveillance. And this showed that if you just did MRI targeted biopsying rather than systematic or systematic plus MRI, you would save 35% of men from having another biopsy, but you would miss cancers in 12%. So there's always a downside. Use of serial MRI, which is something we've also looked at in the management of patients with prostate cancer. 58 patients on active surveillance with a confirmatory biopsy and at least one MRI in follow-up. Positive predictive value 53% and negative predictive value of 80% for Gleason progression on biopsy. And the number needed to biopsy to detect a Gleason progression was far lower for those who had fusion biopsy compared to those who had systematic biopsy, 2.3 versus 8.7. That's number needed to biopsy. Tumor-based molecular diagnostic assays, just to wrap up. There's really two that could be used in this space. Oncotype DX, which uses cancer... sorry, I'm getting them mixed up. Oncotype DX, which allows you to look at what is your rate of non-organ confined or T3 cancer or Gleason grade 4 on RP, so potentially useful if you're looking at an active surveillance candidate. And the Molecular Diagnostic Services Program is now reimbursing for that. Polaris, which is a cell cycle regulatory gene or panel of 31 genes, they have looked at prostate cancer specific mortality based on TERP specimen and biopsy specimen and have been able to correlate that with outcome. The rest of them, including Decipher, Chi67, ProMark, P10, are either not applicable in active surveillance or not recommended by the Molecular Diagnostic Services Program. So the big caveat is there's no randomized clinical trial data for these genomic tests. There's no head-to-head comparisons between the tests so far. None of them have shown cancer's response to particular therapies. There's no data in the active surveillance setting yet on their use. So really we're just extrapolating with what we think they can do to its potential role in that space. So they're not considered standard of care at this time in the NCCN guidelines. Okay, Sorry, long talk. Lots of boring slides, not many cartoons or pictures. Thank you. Thank you.